in this presentation. Take over, Jeff.
Thank you very much, Mr. Otieno Leonard. I'm very obliged for your invitation to share some scholarly principles in nursing. My name is Jeff Tas Olwero, and I'm a registered nurse. And I want to take you guys through patient classification systems. And I'm not speaking for anyone or for any institution. This is purely Let's Talk Nursing. So before we proceed, I want to appreciate a number of people that really worked with me for the success of this presentation. One is Dr. Wagoro, author of mainstreaming nursing process in Kenya. Also, I had a colleague who really encouraged me a lot, Elizabeth Mugi, nursing standards at Kenyatta National Hospitals, and Leonard Otieno, who is the organizer and the moderator for this, and my personal mentor, Professor Nilofa Jivraj, who is a lecturer at Mount Kenya University, and also my supervisor at Workplace Anampio, and Madam Nyarera for the encouragement for the success of this presentation. However, special thanks to my colleagues. We have Mr. Kwena Alan, who is Assistant Chief Nurse at Kenyatta National Hospitals, and the colleagues. I also thank all the audience and also nurse managers who are representing this, who are here and listening for this presentation. So as I said earlier, that we're going to discuss about the patient classification system. So these are methodologies that represent a manpower planning tool, which is uniquely developed for the nursing field. And these patient classification tools has been in existence for over 60 years in nursing and has grown from use in a few selected areas of application to more areas in the nursing system in the whole world today. So this is a very critical tool which is universally accepted and universally utilized in the nursing profession. So the essential purpose of patient classification systems is its efficient and effective matching of the manpower resources to patients' requirement for services. However, there is interest in these systems, which is now, its interest has extremely increased because of their effectiveness in patient care and as well as in controlling the healthcare cost. So this is just an introduction. So evaluation and categorization of patients into different categories help nurses to determine the number of hours required by patient for them for their medical treatment, to calculate the number of required nursing staff, to monitor and evaluate results, and to determine the financing of the health of the nursing services. So there is a conceptual framework before we proceed with the patient classification system. It is conceptualized in a manner of by doing a comprehensive, when you have a patient, you do a comprehensive assessment of the patient, which assist you to identify the nursing care needs. It is this nursing care needs that is used to categorize patient in different categories. However, or conclusively, this patient categorization or classification system tool is used by the administration in the nursing systems to provide human resource, employment, calculation of full-time equivalence, budgeting, costing, evaluation of quality improvements, in the nursing administration. So purely, you may think that this patient categorization or classification is a simple thing, but it is a very intense and a very rigorous tool used by the administrative nurses. So our outline for the presentation, we will be looking at certain terms and concepts and have a background information of the patient classification system, purposes of the patient classification system, and the theoretical frameworks, concepts, and designs that underlines or underpins the patient classification systems, and the principles for designing the patient patient categorization system. And we are also going to look at the criteria for patient categorization and certain examples of progressive or innovative patient classification systems, universal ones. And we're also going to check, which is the most important for this presentation, how to apply patient classification system in nursing systems. And then we're going to have summary and conclusions and references. So there are certain terms which is very important, and it's important for you to note down for us to have an efficient and easy mastery of these concepts. Patient classification system is also known as patient acuity system, and in this sense, acuity is the severity of illness or just the patient condition. We're also going to meet certain terms known as nursing intensity. This is amount of care and the complexity of care needed by patients in hospitals. We're also going to look at the tools, the instruments used in patient classification, and these instruments are administrative tools used to group or categorize patient into a number of care categories according to the perceived requirements requirements of nursing care time. So we're also going to have that. You need to note that down. And first and foremost, patient classification system is an administrative tool used to encompass not only the process of identifying the patient's classification instrument, but also the quantification of the categories of care into some measure of the nursing effort involved, which we are going to see as we go by. So most commonly, the quantification is based on the nursing time involved in direct nursing care of a patient. So another concept that we are going to be meeting is the staffing methodology. So this is a systematic process that encompasses all the procedures and methods used to determine the number and the number and kinds of nursing personnel required to provide nursing care of a predetermined quality to a specific group of patients. These include assessment of the patient requirements through the application of the patient classification instrument. So what we are saying, there are so many patient classification instruments, but we are only going to talk about the universal ones. If we may also mention or name the local ones or the Kenyan model, but our presentation is purely based on the universal patient classification tools. So we are also supposed to note down the term called direct nursing care. So direct nursing care time refers to the time spent by nursing personnel in the presence of the patient or a family. So frequently this always occurs at the bedside, but although not exclusively, sometimes Maybe or maybe not. And there is also another term that we need to note down: indirect nursing care time. This refers to all nursing care time spent by nursing personnel not in contact with the patient. In some studies, it refers to more specifically to activities away from the patient, but in preparation for or in completion of direct nursing care. For example, preparing to admit a patient who has not arrived in a unit. And as well as when you have discharged the patient, there are things that you need to complete. Those are nursing time, but they're not considered as direct nursing. They're not directly related to a patient care. Okay, fine. So what is patient classification system? This is just a categorization or grouping of patients according to an assessment of their nursing care needs, requirements. That is called the intensity over a specific period of time. That specific period of time is the nursing care hour. However, this specific period of time is always in 24 hours. So categorizing present patients according to care needs that a nurse can clinically observe. So these cares, these needs, you should be able to see them or clinically observe them. So when you combine the acuity, which is the severity, and patient's dependence, plus the complexity of the nursing care time, this constitutes the hours of direct and indirect care received by a client, which is called nursing care hours per patient per day. So just a brief history of the patient classification tool. Initially, the patients were classified based on medical conditions, based on their age, and based on the sex. For example, female patient, male patients, we were calling them the pediatric patients, or medical conditions or surgical conditions. So the foundation of patient classification system was first theorized by Florence Nightingale, that is in 1893, which was dependent on the amount of care provided to the patient. So the concepts, assumptions, and principles of Florence Nightingale in 1893 was that, one, it was informal form of classifying patients, where some people will attest, where most difficult patients in an open unit, for example, in a general unit, the most difficult patients were located or stationed close to the nursing station or nurse offices. This was just to facilitate observation. However, the less difficult patients with the minimal care patients were placed or located the farthest in the ward or in the unit, which reflected their reduced ability of dependence to the nurse. So traditionally, the PCS was based on medical diagnosis, age, and sex of patients. However, there was a rift between the doctors or the physician and the nurses, because this kind of application or as a classification of patient did not assist nurses in assisting patients to meet their needs exhaustively. So the recent patient classification systems reflects the acuity of illness. The ones that we yet to discuss reflects the acuity of the illness and type of the care required. That is self-care, intermediate care, and intensive care. All these theories or these concepts are based on Dorothea Orem and Virginia Anderson. So over 50 years, patient classification system have acquired more specific meaning for nursing administration. So the first one, the first formal application of patient classification was done in 1947 by National League Nursing Education in California, that's in US, for the pediatric patient, where they rated the categories of they rated by mean of 3-point scale of intensity on each of the 4 factors. And the factors that were rated were as follows. They were degree of illness, activity, mobility, and complexity of the procedure. And then there was a repeat of the same, which was quite subjective, that category in 1950, which was done by the Army, the US Army, which published by means of prototype evaluation. It was very subjective. It categorized patient as category A, B, C, or category 1 in Roman, 2, and 3. So evolving largely from the work analysis of all these patient classification tools that were invented, they were finalized or analyzed at long last by Johns Hopkins Hospital that has now combined the quantification of specific nursing interventions and patient category by nursing efforts required. These were as per the Virginia Anderson and the role of the nurse. And you'll see how the nursing, the one for Kenya, has also been applied here. This combined system has become what is known as today as patient classification system. So due to the increased pressure on the hospital industry to control the cost, nurse directors or nurse administrators, DNSs, nurse manager, and the rest, the nurse managers along the line, have begun to implement the patient classification systems in attempt to monitor productivity levels. It's also used to predict and justify staffing needs and assist in the budgetary process and policy formulations for nursing systems, both at international and national levels. So in the last 30 years, universal implementation of patient classification system has been exhaustively provided by Joint Commission on Accreditation of Healthcare Organizations, which is approved by the WHO. So the JHAC has provided the guideline of interpreting the patient classification systems using the combined multiple designs of patient classification systems. That is, using both the prototype and the factor evaluation systems. And all hospitals, those who are under WHO, all the nations under WHO, we are bounded by WHO law on patient classification systems that dictates that nursing services and nursing standards 3 shall define, implement, and maintain a system for determining patient requirements for nursing care on the basis of demonstrated patient needs. These needs must be quantified and appropriate nursing interventions and demonstrate the priority of care. So the challenge today is that majority of nurse managers or director of nursing services depend or relies on ward managers for information regarding nursing needs of patients. They have literally some, not all hospitals, not all DNS in Kenya or in the world, they have literally abandoned utilization of a standardized patient classification system. Why? It is because the fear of legal implications of having a patient classification system pointing out staffing deficiencies that budgetary or recruitment factors preclude filling. And it is tough, by the way, to calculate if good in mathematics or biostatistics. So we are going to see how all this is applicable. So the conceptualized nursing theories for patient classifications system are as follows: Dorothea Oren, the self-care theory, self-care deficit, and nursing systems theory. Virginia Anderson, the needs theory, the 14 nursing needs, and the role of the nurse. Also, Professor Faya Abdallah theory of the nursing needs theory, outlining the 21 nursing problems that should be met. Dorothy Johnson theory, the behavioral system that conceptualizes a patient as a whole system. And Gordon's functional health patterns checked about the 11 parameters and how to assist the patient, and Orlando theory of nursing process. There is also the last and least synergy model theory by American Nurses Association, and also Association of Critical Care Nurse as Australian Critical Care Nurses Association, which defined the skill mix and staffing in nursing. So initially, the patient classification systems were based on trial and error, depending on the hospital policies. This was used to determine the staffing needs for nursing care of patients. And you can attest, some of the staffing in some hospitals that we cannot mention are still dependent or are still using guesswork to this trial and errors. They fail because the failures outweigh the benefit due to changing needs of patients. The patient from shift to shift, from season to season, abandon the traditional ways of classifying patients. And if we are managers in our respective institutions, we need to abandon the trial and error method because it is never objective. The concept of patient classification system entails categorizing or grouping of patients according to some assessment of their nursing care requirements over a specified period of time, and the assessment may provide either general indication or a precise measure of amount of nursing care time involved. So there are two designs of patient classification system. There is prototype design and there is factor evaluation design. This is as per the Abdel and Divine of 1965. So the prototype evaluation is too subjective. It's not objective. It is too subjective. It only it's characterized by broad description of varying need levels and characteristics of typical patient in each category. For example, the prototype classified the patient as 1, Roman 1, 2, 3, where 1 means minimal nursing care, 2 means patients that require moderate nursing care, and 3 patients who require complex nursing care. So just descriptive, describing the typical patient without some objectivity of what it entails, what is called minimal care. So the descriptors for category 1 in prototype are as follows. For category 1, these are patients with acute non-chronic episodic disease or disability who will return, who will return to the pre-illness level of functioning, and the care goal complete elimination, and the care goal complete the elimination of the existing health problems. So these are patients who require minimal care. Number 2, category 2 are patients with chronic disease on which is superimposed on acute episodes of illness, who have the potential to return, mark the word potential, to return to the pre-episodic level of functioning, and the care goal managing the chronic health problem by patient and the family without ongoing support from the agency, which is the nurse or the doctor. Those patients also require minimal care. Category 3, patients with chronic disease or disability, where a return of pre-illness function is not possible, but there is potential to increase the level of functioning and rehabilitation. That is category 3. So in the other side of prototype, they have called it the patients who require moderate care. But category 4 are patients with chronic disease or disability who can't be maintained at home without agency support, for whom care goal is maintained at home at maximum level of functioning through ongoing agency support. That is category 4. They require, these are the ones have complex needs, and the other side they're categorized as category 3. However, which kind of patients are these? These are patients who are on home-based care. Maybe they are in need of oxygen, the airway is compromised, and they need the actual nursing care to be done by a nurse practitioner. So category 5 are the patients with end-stage illnesses for whom the care goal is assurance of the comfort and dignity throughout 2 terminal stage illnesses. So end stage. So the prototype, this kind of classification, mutually, its purpose was to establish mutually exclusive and exhaustive patient classification category, which are graded in terms of an ordinal scale in which each category represents a greater or lesser requirement for nursing care. So the methodology is simply applied by comparing the actual characteristic. That's why it's called prototype. You just do it by comparing the actual characteristic of a patient with those described in the prototype. Then you place or you put the patient in that category. If your patient is typically described by what is written there, you just categorize there. So it is too subjective. So when you try to interpret the prototype as per Virginia Henderson on nursing role, the level 1 patients who are minimal, described as requiring minimal care, this is in line with the complementary role of a nurse in Virginia Anderson. Level 2, moderate patients who require moderate care are in line with supplementary role of a nurse in helping the patient meet their needs. And level 3 are intensive and complex patients. This is compared to substitutive role of a nurse as per the Virginia Anderson. So there is also another factor evaluation. This design delineates the specific elements of care for which the patients are rated independently, and ratings on the individual elements are then combined to provide an overall rating, which, when compared with a set of decision rules, identifies the appropriate care category. So this method also intends to provide mutually exclusive and exhaustive category graded in terms of ordinal scale, but with some quantification of care. So what is this quantification? This is how it is done. So category 1, it's just an superimposed of the prototype factor. Category 1 are patients who require, these are self-care patients who require only 1 to 2 hours of nursing care in 24 hours. And category 2 are patients who require minimal care. If we stop from there, that is prototype. But factor evaluation, it has quantified the nursing care as 3 to 4 hours per day. And intermediate care are category 3, requiring 5 to 6 hours per day. Category 4, modified intensive care, requiring 7 to 8 nursing hours per day. And category 5 are intensive care patients who require 10 to 14 nursing hours in 24 hours. The concepts behind this, that the end product of the two types of classification instruments results in the assignment of a patient to a specific care category. The scale for the two types can also be the same, but the difference lies in the method of rating. That is the difference, and the quantification. There are other designs of patient categorizations. They are called the care interaction tools. One, descriptive tool. This is just based on the nurse's choice. The nurse chooses the category that best describes the patient, just using descriptions. Checklist style. The nurse checks the nurse checks the activity. Sorry. The nurse checks the activity levels for each patient in each category and total the points for each patient to determine the level of care as per the Dorothea Orems, whether the patient will require whole compensation or partial compensation or supportive education system. So there is also another one called time standard method. The charge nurse assigns time value based on various activities that needs to be completed for the patient. For example, you receive a patient in the morning and you get a patient with CT scan, chest x-ray, on medications, on mechanical ventilation, but now the charge nurse identify these extraneous procedures, that these extraneous procedures shall increase the workload for the nurse. So therefore, some of the managers utilize this, the time standard method. So what are the criteria for categorization of patients? The criteria for categorization of patients is explained, or we are restricted to categorize the patients. Anyone, by the way, can categorize a patient based on their own way, but it must obey certain principles. These are per the Dorothea Orem's theory of self-care, and each activity must be assigned the level of care. That is the level of interactions between the patient and the nurse, which is involved. That is Virginia Anderson. So the activity of livings that are being assessed are these: feeding, grooming, toileting, comfort measures, mobility. So for example, the area of care, if the area of care involves eating, this is where you want to assess. So if your patient is feeding self, that is category 1. Roman. If the patient needs some help in preparing for eating, that is category 2. If the patient cannot feed but is able to chew and swallow, that is category 4. However, if the patient is not able to feed self and may have difficulty in swallowing, that is category 4. So this patient will require this patient depends on a nurse to provide some feeding to them. And grooming, if the area of care for grooming is the same as for eating. If the grooming for patient category 1, if grooming is almost entirely self-sufficient, category 1. However, if the patient is completely dependent on the nurse for grooming, that is category 4. Excretion, if the patient is up and can move up and to the bathroom alone without assistance, that is category 1. And if the patient completely depends on a nurse to provide a bedpan, not even to provide a bedpan, the patient is on diaper and is defecating the diaper, and it is the nurse to do all this, to do the bladder care and everything for the patient. For elimination and excretion, that is a patient in category 4. General health. If the general health is self-sufficient, category 1. Category 2 needs some help with adjusting positions. And category 4, patient cannot turn without help, but is able to get some drink and adjust positions of extremities, like just sliding that feeding table to the patient, category 4. But if the patient, even if you put the food there, is not able to do anything, that is category 5. Treatment and medications. If the medication is quite simple and supervised, and also simple dressing, category 1. But if the medications is quite elaborate and delicate, requiring 2 nurses to verify vital signs, must be taken for those medications. For example, KCL, potassium chloride, patient receiving norepinephrine, the vital signs must be monitored or must be taken before, during, and after. So more often than every 2 hours, those are patients who are in category 5. Health education, patients who are following routine teachings, these are category 1. Patients but those who are require their initial teaching of care of ostomies, and then they just master what they've been taught, these are category 2. They can do it at home if they're taught. And patient on category 4, more intensive items, teaching of apprehensiveness and mild resistant patients, like patients who are even now requesting to be discharged against medical advice. Those are category 4. However, the patient who does not even want to listen to you, or who doesn't want to listen to any form of teaching from you, those are category 4. Very complex cases. So American Nurses Association has provided a guideline for interpreting patient category based on the prototype and the factor evaluation, which this was adopted by the Joint Commission of Accrediting Health Organizations. And this is what the WHO has also provided. It was this guideline was it is a research that was done by the John Hopkins Hospital. So it said there is something called category 1, 2, 3, 4, and also ABC. So if you are patient, this side I am pointing on the left, these are patient, the criteria, and on the right side are the combinations of needs. These are tools that were used a long time ago, so that's why it has faded. So if once you do all the patients, gather all the patient's needs, and you ask yourself, are all needs marked minimal? If yes, that is category 1. If the needs are not marked minimal, you ask yourself, are there 4 or more needs in the C column? If yes, that is category 4, intensive patients. If no, you ask yourself again, are there 2 or 3 needs in the C column, and is C greater than A? Point A, that is category 3. If yes, that is category. If no, any other any other not falling into the above 3 categories? If yes, this is category 2. So they have said A is for minimal, B is for average patients on A is for patients requiring minimal care, B are for patients requiring average care or moderate care, and C are for patients requiring above and intense nursing care. So the design principles for the patient classifications are 5, and these are validity and reliability. So any principle, any patient classification tool that you are going to formulate must be, we should, any professional nurse should be able to validate it, and it should be reliable, meaning it should be giving similar outcome or findings or similar categorization of patients, regardless of the route we use. Its simplicity and efficiency. A patient categorization tool should be simple and efficient for you. And patient categorization must be objective, and we should not be subjective. It should be easily acceptable by all the healthcare personnel or professionals, nurse professionals, and it must be utilized for nursing work. If its objectivity is not for nursing duty, so the traditional patient classification systems that are no longer in use are as follows. These were done in 1970s. So the traditional patient classification tools were med-surg classification systems, pediatric classification systems, psychiatric classification systems, and patients were categorized as long-term care patients. So, the universal ones, or the innovative or the progressive patient classifications systems are 5. If we don't mention the nursing, the case of nursing, the case of Kenya. So we have Johnson patient classification system, which is categorized. Patients are categorized based on Dorothea Orem and Virginia Henderson's. That is the level of care and the care needs. Category A, we have explained what it is. And there is also another progressive patient classification system called nursing intensity classification system. This was basically used in the med-surg unit. It is just it's a superimposed superimposed on Johnson patient classification system. So it is used in the general nursing units to assess nursing workload, and it was based on Orem and Virginia theory of nursing. And this tool is very important because it tells you how, or the level of the dependency of a patient on a nurse based on the nursing care activities. So this one is described as the factor evaluation system. So its main purpose was to determine the level of nursing care, assist in staffing decisions, and manage workload. And also the descriptive factors were patient dependency factors, that is physiological stability, mobility, cognitive status, and nursing care activities. That is assessment, treatment, and interventions. And the scoring method for this was numerical scoring system to quantify the nursing workload for each patient. Just quantifying the nursing hours required. Example is this. So its application is on. It's very important for equitable resource allocation in nursing units. There is also another system called therapeutic intervention scoring system, that is the TISS, primarily used in ICUs. It is not used in other areas of nursing, but primarily in ICU. So it only requires you to first classify the patient as per the Johnson's or the NICS, the nursing intensity classification system. Then within that unit, you reclassify your patients again based on their acuity and the level of care required as per the Virginia Anderson. So it focuses on intensity and the therapeutic interventions. So the scoring method was as follows. It assigns numerical values to interventions performed, e.g. the procedures, by giving out or describing the turnaround time for nursing procedures. If you are supposed to do a bed bath, maybe a bed bath, it defines the maximum time or period you need to take when providing a bed bath. Medication, this kind of medication, how long should you take to give that medication? That is the therapeutic intervention scoring system. And scores are summed up for all interventions over a specific time period of time. And then you need to know that this patient, out of the 24 hours, how long was the nursing how long were the direct nursing hours? So the benefit is it is used to manage workload, making staffing decisions, and equitable resource allocation. So this is a very critical and serious tool because it prevents the guesswork, the trial of error of redeploying or rescheduling staff. I don't want to mention certain hospitals that we know. This is purely let's talk nursing. There is another classification called All Indian Institute of Medical Sciences system. So it was developed by All India Institute of Medical Sciences in the New Delhi, just in India, but it is primarily used in tertiary levels and medical colleges, not at industrial. So it classifies patients into categories based on the disease, severity, complexity, and resource utilization. So this one is not even used in the whole world, but majorly in the Indian areas. So its application is that it helps determine the level of care required, resource allocation, and planning. So it only categorizes patients as category 1, 2, etc. Then there is also another one called case mix grouping, which is very common in our government institutions. It's employed in private hospitals and private hospitals. It is based on principles of medical diagnosis, surgical procedures, gender, and comorbidities. For example, we are classifying patients in certain hospitals as medical unit, as surgical unit, then comorbidities like oncology patients, female ward, male ward. So it only assists in predicting the patient outcome, but it has got nothing to do with staffing allocation. But we can also utilize it for resource allocation and reimbursement. So the Kenyan model, which is also regarded as progressive because it was invented recently in 2015 by none other than, I hope she is a listener here, called Professor Wagoro, a lecturer at University of Nairobi. They did the mind behind the mainstreaming nursing courses in, and they developed a curriculum manual, and they categorized a patient as category A, category B, and also category C. So their categorization was based on Virginia and assumes the nursing roles of assisting the patient meet their need, and also their theory was apparently also based on Dorothea Orem, or theory of nursing of self-care, where they talked of full compensation, partial compensation, supportive care. That is purely Dorothea Orem. And the nurse role, compensation, full compensation is the substitutive role of a nurse, and category B is the supplementary role of a nurse. Category C is complementary role of a nurse. So how do we apply patient classification systems in nursing systems? As I said earlier, the concept is, you might think that the patient classification system is not that useful at the bedside, but it is very useful administratively. So it is the human resource management tool for the nursing division. Without it, without the patient classification system, the human resource management in any hospital for nursing will be poor. So how is it utilized? It is used for duty allocation and staff mixing. But how? So the most common application of patient classification systems begin the head nurse. Classifying it is the head nurse to classify all the patients on a nursing unit once per shift. The head nurse can be a team leader, can be a floor cover, can be anyone in charge of that unit, including the director of nursing in that hospital. So this is usually done in a predictive, so that care requirements for the next shift will be determined in advance. So based on the quantification identified for each category of patient, that is the nursing hour, an estimate of the direct care workload is derived. So the direct care workload that we had defined earlier is then added to the time required for the indirect care activities. And then it is distributed to all other nursing personnel activities. That is, whether you have KRCHN, Higher National Diploma, BSNs, Masters, etc. available as per the duty rota. So the result is an estimate of the total man-hour required, total nursing hour required. This is matched to the man-hour scheduled for that shift, and staff allocation is altered based on the match. So if the number of the time for the man-hour is more than the nursing hours required for all the patients, I let you know you are in charge will always release a nurse to another unit to go and cover where there is more workload. So it is important to know that swapping of duties must not be done by the individual nurse, but must only be authorized by a charge nurse, because they are in possession of their patients' categories at all times. So having quantified the care requirements of patients according to the designated category as per the shift, the concept of global average hours per patient per day as a standard for determining staffing requirement is replaced by a method which is more efficient for rescheduling a staff. Another concept for another applicability for patient classification system is nurse staffing. It is used for nurse staffing and staff scheduling. How do we staff? and schedule a staff using a patient classification tool. So staffing is just a process of determining and providing the appropriate numbers and mix of nursing staff or the nursing care hours to match patient care needs, patient care hours as per the patient categories. So having known, please, when we are doing this application, master those prototypes and also the factor evaluations, designs of patient classification. So the main goal is to provide an effective and efficient nursing care. But how? So you need to determine the number of staff needed. Managers must also examine the workload patterns for that unit in the hospital. So it can be done by taking average daily census of patients and category and hours of care provided in 24 hours a day, or utilize the 7 days a week. So staffing is a challenge in health care settings as patient census keeps on varying. You can't predict today you have 50 patients in an hospital, tomorrow you might have 60. So from being steady in certain periods to certain and also months such as during an outbreak of cholera, it's never steady. So sometimes also a staff may call sick, but you have 50 patients and you had predicted that you require 10 nurses, but a staff has just called in sick. So what are you supposed to do based on the patient category? We are going to see. So the nurses schedule may not have the skill. Sometimes also the nurse schedule for that shift may not have the skill set necessary for a patient condition as per that category. For example, some hospitals deploy non-specialized nurses in a specialized unit. And in that specialized unit, you have 10 patients who require specialized care. So the need of the patients exceeds the skills of the nurse. So will the patient be safe? I guess no. So who determines the staffing criteria in nursing? It is determined by Joint Commission of Hospitals Accrediting Body and the American Nurses Association by identifying the staffing requirements. So they specify requirements for staffing systems. If you want that, go to American Nurses Association of 2012 to define how you need to staff your unit. So the decision matrix for staffing, as per this was adapted from Nursing World. The patients you need to know the characteristic and number of the patients requiring the care, intensity of the unit and care. You need also to know the context and expertise of yours and any other things to check quality improvement activities and nursing control of practice to assess the patients. So for example, a patient in category C, as per the Universal Patient Classification System, or category in this Kenyan model, needs more time of nursing care than a client in category A, that is in Universal Patient Classification System, patient or category C. So I hope managers are mastering this. So the traditional systems of staffing are based on the number of per unit. For example, you can allocate one nurse per 4 to 6 beds. So the system nurses based on the manager's opinion of the proportion of the that is needed on each shift. This was more of a guesswork. It has got no rationale or scientific background. So the disadvantage of this traditional method is that it ignores that the group of patients need more care than another group of the same number. So traditionally, the determination allocation of nursing personnel has relied heavily on global approaches, makes use of fixed nurse to patient ratios, which does not respond to patients' needs. So it has long been recognized that these ratios are insensitive to both relations between the institutions and among individual patients. So utilize the patient's classification system, innovative ones, in staffing is very crucial. Are categorized based on the level of acuity, level of nurse-patients interactions as follows. So just the way we said earlier, you first need to categorize your patient like this, or as per the John Hopkins, based on universal categorization as per the American Nurses Association 2012, you can categorize like this and quantify the care. So it is used to determine nursing hour care per patient per day. Once you do that, so a measure that quantifies the nursing time available to each patient by available nursing staff. So the patient workload trends are analyzed for each day of the week, each hour in critical care to determine the staffing needs. So this is known as nursing care hours. So it is used to evaluate the level of patient and the ratio of staff to patient. So how is it done? You only need number of hours by the nurse per the labor law. Assume it is 40 hours in a week or 8 hours a day or 12 hours a night. So number of patients per unit, you also need to know the number of patients per unit and their respective category or acuity level. So assume you are in a male ward of 40 neuro patients, and you have, so you distribute them as per their acuity levels or categories. So you have 7 patients in category 1. Hours is 2 hours, so you need 14 hours. 10, 6, 60. 13, 7, 91. 9, 90. So you will require 255 nursing hours in a day for all these 40 patients. So in average, you will require 6.375 nursing care hours. So those who have been giving reports to DNS, you know what is the nursing hours. This is a classification tool to determine the nursing care hours of that unit. So this one is important for workload. So this nursing care hour that you are seeing here is very important to determine the full-time equivalent. That is to employ staff or to pay nursing staff on permanent and pensionable, putting staff on full salary. So you need to know, using the patient classification system, how many nurses you require to put on a full salary and how many nurses you require to put on locum, just based on patient classification system. But how is it done? So full-time equivalent represent the number of working hours that one full-time employee completes during a fixed time. So the full-time converts workload hours as per the category into the number of people required to complete that work, which can help to simplify scheduling. But how is it done? Suppose you have an employee who works for 5 days, like us. We work for 5 days a week, official hours, or 40 hours per week for 52 weeks in a year. So full-time equivalent hours are total of all paid time. So using the patient categorization categorization system, you need the number of full-time times the total weekly hours times the total number of weeks, which is 1 nurse times 40 hours, working for 40 hours a week, times 52 weeks, working for 52 weeks, will work for 2,080 hours in a year. So when you're calculating this, one full-time in nursing is done by combination of the staff with comparable expertise. You cannot just put this nurse in a hall to work from January to December. You need to mix them. So for example, one nurse may work 24 hours per week, and 2 other nurses may each work 8 hours a week. So all this will result into 40 hours a week. So together, these 3 nurses fill 1 full-time equivalent for a week. So the method to determine the number of patients or full-time equivalent requirement for staff to staff a unit in 24 hours a day or 7 days a week, you need the total hours worked per full-time equivalence in 1 year, which is per nurse, which is 2,080. So when you have that full-time equivalent hours for 1 employee, you need to know the total nursing care hours from that word. Assume we are using the example of this, our neuro ward. We required 255 nursing hours. So what are we going to do with all these so many difficult mathematics? The formula in care hours in a year worked per 1 full-time, you will get 44.75 full-time equivalents. So you require 45 nurses to run a med-surg or a neuro ward of 40 patients based on their acuity. So you will only need 45 nurses. Less than this, you will always understaff. More than this, you overstaff. So other factors to consider for staffing include, other than the patient category, we need to know personnel policies, that is job, overtime, part-time, work, leave, and other assignments, education level of staff, job, and market competitions. Do not exclusively use patient categorizations to provide staffing and staff scheduling for your unit. There are other factors to consider. We can also use patient categorization to staff, for staff deployment and staff redeployment. For example, when you utilize the synergy model of nursing theory, so once the patient is categorized, managers match the patient needs with characteristics of a nurse. So, for example, category 1 patients who require minimal care only require KRSHN plus a supervisor. Category 2 can require KRSHN, BSNs, and supervisors. Category 3 patients might require higher national diploma, specialization with BSN or masters and a supervisor. Category 4 require higher national diploma, BSMSNs, and above the higher orders of nursing in that system. If you follow this, the patient quality isn't guaranteed at all. Quality is also applicable for quality improvement and quality assurance in nursing. So it's a measure of the quality practice in nursing care. So quality care to patients can be done through balancing workload through staffing and scheduling of nurses. So it helps in assessment of training needs also of nurses, providing real learning experience based on the nursing needs of patients. So when you are running a CME, you'll be running CME based on the categories of patients or based on the patients that you deal with on a daily basis. This will improve the individual knowledge, skill, and expertise in your CMEs or in your unit. So it is also applicable for national budgeting and as a health advocacy tool. But how? So during the formulation of national health policies in regard to nursing and midwifery practices, patient classification tool is used as a tool to solicit for manpower and material resources that the patient need. So for example, category 4 or category A for our nursing model will require more manpower, mechanical ventilators, cardiac monitors, hemodialysis machines, and other medical equipment requiring for patients, requiring specialized services. So it is also used to determine reimbursement rates or funding from national government and international organizations like WHO and others based on the complexity and severity of patients' conditions. So don't think it's a very simple thing. It's very important. We have explained how it is used for quality improvement. However, it is a tool which is used by managers for the quality management system to identify the trends and variations in patients' populations, leading to targeted interventions, effective communication, improved patient outcome, and enhanced patient safety. It is also a tool which is used in advanced or developed countries for billing and costing of nursing services. So more complex nursing cares in category 4, 5 are billed and costed higher than those in lower categories. So, e.g., using turnaround time, we are using the time used or taken by the nurse to deliver that procedure. So, remember, time is money. In advanced hospitals or in advanced nations, they are using the turnaround time for nursing care to charge the patient. And it is incomparable to what nursing in Kenya, billing and costing of nursing in Kenya, where you do too much to a patient and a nursing service is only 200 shillings. But doctors do spend less time with the patient and charge 10,000, 150,000, or even up to 500,000. In summary and in conclusion, so for quality management systems in nursing divisions, we as nurses, we are advised, this thing is a process. It starts with implementation of the nursing process using the nursing care plan. It will help you identify, if you utilize your nursing care plans at work, it will help you identify and quantify nursing care needs of patients. This will result into better categorizations of patients. And when you do the good categorization of your patient, the administration will always respond to the patient need by providing human resource, by proper budgeting, costing of servicing, and evaluation of quality of care. So we advise or we recommend all direct nurses and nurse managers should integrate this tool and implement it for the continuous quality improvement initiatives within the quality management systems in your nursing division. So challenges that influence the implementation and application of the nursing care. This is something that you people can do at your individual institutions, evaluating your individual institutions why you cannot implement this. And are you aware that this tool is an administrative tool? There are references, but I want to acknowledge the presence and the work of none other than one of our own nurse in Kenya, as this is Professor Dr. Wagoro Andrakuom, this for mainstreaming nursing process in Kenya. And that marks the end of the presentation, and I would wish to take the baton back to the moderator. Thank you.
Thank you very much, Jeff, for that presentation, which was very nice. And we really captured a lot. We might have some questions from the floor. So if you have a question, you can just start right away. Jeff, there are some questions that I have assigned you already. There's also another person, Rofina Musengeti. I know Rofina Musengeti is from Coast. is requesting if we can delve more on calculations next time. It is not clear. So Jeff, you will respond to that. You can just take those as continue.
Where are they? I'm trying to.
They are in QA.
The QA.
Yes.
I hope you guys are able to hear me. I can see someone is saying that they have lost me.
We are able to hear you.
Okay, thank you. Yeah, for Mr. For Muganda Brian, this shall be the slides shall be distributed by the presenter, by the moderator or the organizer for this. So don't be worried about that. So where are the questions? Q&A. I scroll down.
Yeah. Just check. There is a Rofina Musengeti from Uganda. Below it, there's some other questions.
Rufina is asking, we need to delve more on the calculations next time. It's not clear.
Yes.
I know it is a very complex one. I know, so when I said that the calculation of the nursing requirements, full-time equivalents, if you're not good in mathematics or in biostatistics, it might sound Greek or Latin first, but with the time, we are going to improve, and I assure you, you'll understand. Thank you.
Thank you, Betty, for that. Then there is someone also saying that Angeline joined late. Is it possible to get presentations so as to read and try to understand it? Jeff has responded to that. Then someone is, how often can we have these meetings done? We'll discuss this in the group, Let's Talk Nursing Forum. Then we'll give you feedback. Just send us your email in case you're not a member of the Let's Talk Nursing. But we'll also advise that you join us if you are a nurse to join us in Let's Talk Nursing. We'll wish to, yes, we will unmute you, Alfred, so that you can make some comments. I came a bit late. Jeff, you can go through as I.
Yes, I'm able to see how many nights. Someone is asking, how many nights should one work per week before earning night offs? We appreciate your question, Mr. Frederick, but for patient classification system does not define how many nights one needs to do. So how many nights one needs to do before earning a night off is dependent on the hospital policy and the labor law of you need to work for 40 hours, minimum of 40 hours a week as per the International Labor Organization law, 40 hours a week, or a maximum of 48 hours a week. So your institution needs to coil their policies towards that, of which I think they do. But you must be cognizant that you must work for 40 hours a week in every institution. That is at least. So if you're in government, like government of Kenya is utilizing 40 hours a week. If you work in private institutions, I assure you, because they want to maximize the profit and minimize the cost, you will have to work for the 48 hours as per the labor law. Yes. However, I'm very categorical. Patient classification system is not used to determine the number of nights that you need to work before earning a night off. Thank you. I hope I'm clear, Mr. Frederick. We also have someone saying, thanks for the great presentation, though despite joining late, I am also interested in knowing the categorization of mothers in labor. That's not so nice. Also, you need to have the prototype and the prototype designs, and also the factor evaluation system, and describe, identify the needs of the patient and try to allocate those needs as per the prototype. You will know where your patient falls. So these are universal things. They are applicable anywhere. Even if you design a new form of categorization, it will always fall within that design. And I hope I'm not very harsh on your response. But for your categorization of patients and mothers in labor, please just assess their needs. Do not routinize. The different mothers in labor have different needs. Even though the common goal is the delivery, but their needs, nursing needs, are different depending on the severity of their labor. Some comes with the normal labor without complications. Some come with labor with complications and obstetric emergencies. Some come in critical conditions that require intensive care. So please, you'll be able to do it. Just utilize your nursing care plan or nursing process. Kindly share the slides by Kanini. That's okay. Joachi is also asking for the same. And Betty is asking a very pregnant question. Should managers be discouraged to float non-specialized staff to special units? If so, how should we approach on job training for those with interest in the said areas? So this is a very ambiguous and complex question, because based on the experience I have at our workplaces, many workplaces we have, I'm not speaking for any institution, I've seen managers offloading specialized staff to non-specialized unit, or floating non-specialized staff to to specialized unit. We really need to discourage this if we really want to improve our nursing. If we really want to provide an environment for the patient to have a high quality or quality experience of nursing care, this needs to be discouraged. However, the only policy developers and those who are in authority have the final say. So for the training purposes, I would say yes, we should discourage. For the practical things on the ground, or the ideal, we only need to encourage the nurse directors to be cognizant of the suitability or the use of patient categorization systems. This will help them in rescheduling and also redeployment of staff to various units. Thank you, Betty. And also you're asking, if so, how should we approach on job training for those with interest in the SAID? On job training, okay. So if a manager just overlooks patient classification system, or feels it is okay to have a skill mix for the non-specialized and specialized nurses in a unit, it is important to organize competency-based trainings, which are on-job training for the non-specialized, for them to have an encounter and improve their knowledge, skills, attitude and experience in managing the complex patients. Those are patients in category 4 or category A in universal category, or patients in category A, the nursing model. Someone is asking, what is the classification of patients in the ICU? Based on which category? Based on Johnson, it is category 4. Based on Kenyan model, it is category A. Based on universal categorization criteria by American Nurses Association, it is category C. But we are encouraged to use the therapeutic intervention classification system that we have discussed, that tool, the method. It will give you clear patient category. Mr. Otieno Leonard, I hope this is
okay.
This is the last question.
I'm seeing just a minute. I'm seeing Ronald and Dorcas hands are up, and I will allow them to talk. You can go on. Any other question before we end this session?
So as this chief speaker, I'm saying that what I've presented is not final as it is. You are expected to be innovative, and we are also expected to adhere to rules, institutional policies, rules and regulations, and the nursing standards that govern our practice in our various countries. So if it is in Kenya, we adhere to the regulations or policies provided by the Nursing Council of Kenya.
Abdi, Dr. Abdi, I'll allow you to talk. So accept from your side. Abdi Malim. You need to accept if you want to talk. Rufina. Rufina Musengeti, Dr. Abdi, Alfred, Dorcas, we are waiting for you before we have a few minutes remaining.
Yeah, me.
Yes, we can hear you, Dr. Abdi.
Yes, thank you. Sorry for that technical glitch. Mine is just to say to really appreciate Otieno for this very, very wonderful presentation and unique in its own setting, actually. This is an area that has not been dwelled very much. And it is very, very important that we really need to use this, particularly where we have right now so many nurses not working. At the same time, huge shortage at the various places of our facilities, of places of work. This is where we need the regulatory bodies and other entities, the nursing, what do you call, leadership to use this methodology to maybe press for more recruitment of nurses, so that we don't also risk the patient's lives and also the nurses health-wise, because when you have got huge number of patients and delivering maybe 3-4 mothers and you're only one with a student nurse, that really risks the life of the patients and the baby, plus also the nurse. I think this is a very, very important the tool that we need to use. It reminded me, I'm sure those who are at the early stages of Moy University, we used to use this full-time equivalent faculty allocation when we used to do the requirement for the various faculty, because we were new, creating up our own faculties, and we were being told every time, can you prove using the full-time equivalent or the number of staffs that you require? I think this is very important. Thank you very much, Otieno, and I hope we will continue to see more lights as we go with the other presentation. Thank you so much.
You're welcome, Dr. Abdi. Dr. Abdi was one of the chief speakers in the NNK conference in Bungoma. So for those, I think you can remember. So we can proceed on. Waiting for Rofina, Eric, Dorcas, and Alfred. I've accepted your invitation, so you can just unmute yourself. Thank you very much, Jael, Sylvia. Sylvia, next time you have a presentation for preeclampsia. Margaret, Susan, you are most welcome. Alfred. Rufina, I allowed from my side. It is you to accept. Let me try it again. Rufina. So we can end it from there if we don't have any much questions. For those who are asking for slides, I will consult with the presenter so that I send you, but you will also get the presentation in YouTube. Let's Talk Nursing YouTube. We also sent a link in our Let's Talk Nursing forum.
Hello?
Yes, yes.
Yeah. My name is Shema. I want to thank Leonard for this next presentation. That's really enlightened us, and we hope for more. Thank you so much.
You're much welcome, Eric. Dorcas.
Mwaka yangu kile ambacho shetani aliiba kutoka kwangu lazima alikapita, na nimeona kuna watoto wangu.
Alfred, I can see your hand is still up. I think we can end it there. Thank you very much once again, all the nurses who attended. Just a reminder that our presenter was Jeftas Olwero. Jeftas is a nurse